Hello. I would like to thank the organizers for allowing me to participate in this session. I've been asked to talk about neurological emergencies. In the 20 odd minutes that I've been given, I decided to deal with a headache that we often have to deal with. Okay. And to illustrate my approach to headaches in the emergency department, I've decided to choose two cases that I've heard in. I'll discuss at length the first case. The second case, perhaps we can discuss live during the question and answer session. So it was usual Wednesday afternoon when my resident and I were rostered to go down to the emergency department to clerk the patients that were waiting to be admitted to the hospital. So the first patient that was in the list was a 21-year-old lady who was admitted for headache, who was waiting to be admitted for headache. She had generalized throbbing headaches for the last 2 days. She had minor episodes like this before, quite a few times in the last 2 years. Okay. Now, while looking at the emergency department paper notes, these were some of the phrases that we got. That patient looks quite well. She was given some analgesics and observed in the emergency observation room. And a few hours later, she did not get better. So a decision was made to do a CT scan. CT scan was normal, and then she was then waiting to be admitted to neurology. So while my resident went ahead to get the cow, not the animal cow, this cow stands for computer on wheels, which is basically what we use in our hospital to clerk patients. While she went ahead to get the cow, I decided to quickly talk to the patient and did a quick examination and basically added on to the information that was already provided by the emergency physicians. Basically, she was indeed having headaches for the last 2 years, very similar in nature, and the neurological examination was completely normal. She was afebrile, vitals were normal, and she had no neck stiffness. So as my resident came back with the computer, I straight away turned to her and said, "This is just probably migraine. Let's start treatment and let's go on to the next case," while she's waiting for admission. At this point, my resident politely turned to me and said, "Doctor, I think we need to take into account a few other pieces of information from a past medical history, which I have managed to elucidate by looking at the electronic records." Basically, this lady has got lupus since the age of 12, and at the age of 18, she was transferred from the pediatric rheumatologist to the adult rheumatologist in our hospital. And lupus was complicated by severe lupus nephritis. In the last few months, they have been struggling to control hypertension, and the kidney disease was also getting worse. She was on large dose of steroids, and they've recently upped the immunosuppressants too. At this point is what I refer to in clinical medicine as the still point in the turning world moment. When everything's still moving around you very fast, but you feel like time and space has stopped. Because I realized that I fall into a classic trap of in clinical medicine called the framing bias, where you can come to different conclusions depending on how this information is provided to you. Okay, and as we discuss this case, you realize that this case illustrates other common biases that we have in clinical medicine, biases like confirmation bias and anchoring bias. Okay, so these biases are particularly common when we deal with headaches. Why? Because headaches is unique in clinical medicine. Unique in clinical medicine because it can be both a disease as well as a symptom. Now, this is going to be a problem. This is almost like you decided to install a fire alarm in your house. It rings whenever they were supposed to ring whenever there's fire. Okay, when it rings, you know it's fire. Okay, so, but if it rings and occasionally there's real fire, but sometimes it rings because it is sensitive. For some reason, the alarm itself is sensitive and it's tripped off by maybe a draft, a wind, or maybe a pet that flying, your pet that's just running across the alarm and trips it. And then it's an oversensitive alarm and it's ringing even when there's no fire. But how will you know when there's true fire and when it's just the alarm is too sensitive? That's going to be a real problem, because if you ignore the alarm when there's true fire, you're going to burn down with the house, right? On the other hand, if you wake up every time the alarm rings, okay, you're never going to sleep and you're going to go mad. So headache is like that, because you have pain, which is usually in other parts of the body. Usually an alarm to indicate pathology in that organ or in the system, okay? But here, it can be a symptom like of pathology in the organ, which is the nervous system, like meningitis, subarachnoid hemorrhage, or intracranial hemorrhage, or raised intracranial pressure. Any of the pathologies can give rise to a symptom of headache. But at the same time, you have diseases, primary headache syndromes, like migraine, trigeminal neuralgia, cluster headaches, which can be very, very severe and recurrent. But no matter how severe or recurrent they are, they don't indicate any specific pathology, but they are just recurrent headaches on their own merit, right? Occurring on their own merit, just like an alarm that's just hypersensitive and it's just ringing for whatever reason it wants to ring for, right? So your challenge is to decide when is it a fire and when is the alarm too sensitive, okay? So therefore, if for such a complex disorder, therefore, although it's common, headache is actually can be complex. If you do not have a systematic approach, a deliberate formulaic thinking, and you rely on gut feeling, then you realize that often you're going to be wrong, and both you and the patient is going to suffer. So you need to have a system, an approach to headaches. And what is the approach that I would propose? This is the 3-question formula or approach to headaches. Okay, it's based on 3 buckets of questions. First, understand what is the headache, nature of the headache, especially the headache that's been going on for a while, as well as the current headache. To understand whether it fits into one of the classic syndromes like trigeminal neuralgia, cluster syndrome, because all these have very characteristic features which you can easily access in your textbook or in your electronic references. Then think about the red flags. The red flags basically is a list of questions to indicate that this is likely to be underlying pathology and this headache is a symptom rather than a disease. So it's meaning that there is real fire in the house, right? And then finally, you have to put it in context of the patient. Understand what this means in context of the patient's demographics, as well as the comorbidities of the patient. Okay. Then you put all these 3 things together and then you stir it up in the cauldron and then decide, is this likely to be a primary headache syndrome and therefore you just treat the patient aggressively for the pain? Or are you going to search aggressively for the underlying cause? And if it's an underlying cause, what is the underlying cause? And what is your approach to investigating this underlying cause? When do you decide to do a CT scan? When do you decide to do a spinal tap? When do you decide to do an MRI? When do you decide to do a MRA? And when do you decide to admit? When do you decide to discharge the patient? All these things will depend on this particular part of your algorithm. So I'm going to use this example to illustrate how we subsequently, the resident and I corrected ourselves, and tried to help this patient. Okay, so we went through and said, let's start the game, this time by applying the 3 questions rather than just using gut feeling and say, she looks well, okay, which I did initially, probably migraine, let's move on to the next case. So what did I do? First question, now, what is the headache profile? Indeed, her headaches are sounding like migraine in the sense that they're recurrent, throbbing, one-sided headache, they're often intrusive, she needs to take time off, and sleep in a dark room. She gets very irritable during those times. Often during menses it comes on and it can last half a day. And during that time she doesn't like loud noises or bright lights. And often she has to take some analgesics. And after a few hours the pain will go away and then may come back again a few weeks later. Okay, so she does satisfy criteria for migraine. So that's what she has in the background. What about red flags? Now, to be systematic and comprehensive with your analysis of the red flags, I would suggest a checklist, just like a checklist that a pilot uses, because a pilot's prerogative is to be safe 100% of the time, not 99% of the time, 100% of the time. So therefore, he has to use a checklist to be safe all the time. So likewise, for us clinicians to be safe in our clinical methods, we should have checklists that are deliberate in nature, that are discrete in nature, so you know exactly how many questions you have to ask. At the end of it, you know you are comprehensive and you cover the bases. So here I suggest 5 questions. What are the 5 questions? Number 1, do you have symptoms and signs of focal neurological deficits like weakness of one side of the body, double vision, dysarthria, dysphagia? And she has none of these. This lady had none of that. Okay. Then we asked her, do you become very drowsy during this time when the headache came on, or did you lose consciousness? Did you faint? And then the patient says no. But at that point, her mother, who was standing a few feet away, politely standing there, observing what was happening, decided to come in and interrupt. Doctor, I'm sorry to interrupt. I heard you asking my daughter about fainting. As a matter of fact, the first thing that alerted us to something was wrong was my husband and I heard this sound of a sudden thud, boom, in the room, in her bedroom. And then we opened the door, went in, and we found her lying on the floor, and she was half drowsy and very lethargic. At that time, she was clutching to the head, and she was saying, oh, she's having some headaches, you know. And then we asked her, has she has had fainting spells like this before? Any previous fainting? She said, no, this is the first time, you know, and her previous migraine spells, of course, she has got no fainting spells, you know. And this time, although the headache started before the fainting, she did have a definite fainting spell at the beginning of the, somewhere close to the beginning of the headache. So that kind of like perked us up, because we realized that there was indeed a red flag, which we initially I missed in my cursory evaluation of the patient. But when I went through a checklist, the patient herself denied it, but her mother heard it and came and reported. Okay. Then we went on to the next question, which is a whole series of questions like vomiting, blurring of vision, headaches are worse on lying down, headaches worse on coughing or Valsalva maneuver, which suggests raised intracranial pressure. Then we went on to ask for symptoms and signs suggestive of meningitis. And initially the patient says no, but again the mother said actually the day before, after the fainting spell, they decided to check her blood pressure, which I'll come to in a minute, and the temperature. And the temperature was actually borderline, 37.7. And as I mentioned earlier, she was lethargic the day before. So again, well, nothing very, because it's low-grade fever, not very sure whether it's definite red flag. That's why I cannot put it in the pink flag. Now, the question number 5 in this checklist is basically the character of the headaches. You know, some characteristic symptoms are not common in primary headaches. So therefore, we take more attention, we pay more attention to them. For example, primary headache syndromes, most of them will build up slowly over a period of time. They never, maximum at onset. At the beginning of the headache, 10 out of 10. Now that's very rare. That's known as a thunderclap headache. That's very, very rare in primary headaches, but that's common in subarachnoid hemorrhage. So similarly, some of the other symptoms that I've listed are uncommon in primary headaches. So this question number 5 actually refers to all the symptoms that are uncommon in primary headaches. So she reported that her headache was quite severe, which by itself is not a red flag. That's why I put it in pink. But there was some change in character. It wasn't the classic throbbing headache and that goes off in half a day, but this is a bit longer and a bit more generalized. So there was a little bit of a suspicion there. So 1 definite red flag and 2 or 3 pink flags. Okay, then of course, the third question is about the patient's comorbidity, and I kind of elaborated on that. And although I said earlier on that the vitals were normal, I realized that I didn't look carefully, because I thought she was a young patient, that I didn't look carefully at the blood pressure. Actually, her blood pressure was very high, even in the emergency department. And the family reported that the blood pressure has been persistently high. And as I mentioned earlier, the renal physicians and the rheumatologists have been struggling with controlling her blood pressure the last few days. So this was the basic scheme that I applied, that my resident and I applied on the patient on the relook, and we came up with this data information. But what do you do with this set of information? So what? Okay. So well, based on this, then you decide what is your pre-test probability of this being a primary headache syndrome, worsening of a primary headache syndrome, which is migraine, because of course she has migraine, so she's entitled to have a migraine. Just because she has lupus doesn't mean that every time she comes to a headache must be serious. So it could just be. On the other hand, is there a possibility that this is something more sinister? And what is the pre-test probability of that particular sinister condition? And depending on the pre-test probability, what test is appropriate? Meaning which test is sensitive and specific enough for that level of pre-test probability. So that's what we did subsequently. And that's what I've listed here. So we decided, my resident and I decided that she could have some form of hypertensive encephalopathy, which is known as posterior reversible encephalopathy syndrome, which is common in patients with severe acute hypertension, especially in autoimmune disorders. It's a form of hypertensive encephalopathy, but particularly seen in autoimmune disorders, characterized by raised intracranial pressures and severe headaches, and sometimes with signs and symptoms of raised intracranial pressure. So we thought that was possible. In fact, probability was quite high, so we listed it right up in the top. And then because she's got nephrotic syndrome, which is a procoagulant state, she also has lupus. And at that point, we didn't know whether hers was associated with antiphospholipid syndrome. So that means she could be procoagulant, she could have cerebrovenous thrombosis. That again, we thought was significantly high enough in the probability list to put right at the top. Now, meningitis, she had low-grade fever only, but remember, she's afebrile now. She looks completely non-toxic. She's well. She's got no neck stiffness at all. So probability of meningitis is not high, but I wouldn't put it as 0. Why? Because she's on immunosuppressants. So we put it as moderate probability. On the other hand, the nature of the headache, the way it came on, it didn't come on sudden headache, and it didn't come on as a thunderclap headache. So we thought subarachnoid hemorrhage was low in our probability. Intracerebral hemorrhage was even lower because she had no focal neurological signs during neurological exam. So these two were so low that the current CT scan that's done is sensitive and specific enough to rule that out. But we thought that for PRES and CVT, it's high enough probability that a plain CT scan is not sensitive and specific enough. We needed an MRI and MRV on admission. Okay, so the admission was definitely justified, and because the patient needed MRI and MRV to rule out these sinister causes. What about meningitis? Because I didn't think it was very high probability, I didn't immediately culture and start antibiotics. But because it is not low probability, I cannot dismiss it. I decided to screen with tests of moderate sensitivity and specificity, ESR, CRP program. Now, if she was high, if let's say her neck was stiff, she was drowsy, she was spiking fever, then I wouldn't bother. I mean, of course, I'll do it, but I wouldn't take this test so seriously. I would straight away go on, do the blood culture, start antibiotics, and arrange for spinal tap. Correct? But here, the probability was moderate. So therefore, I can screen with this. Okay? And then we left instructions for this test to be done, and then for the on-call registrar to call us. And we went on to clock the next patient. As we finished the next patient in the emergency department, we got wind that the results came back, CRP and ESR was super high, procal also. So we straight away thought, okay, pre-test probability of meningitis was moderate, but the screening test is positive. So we definitely have to culture, start antibiotics, and plan for spinal tap in the ward. In the meantime, she was waiting for MRI, right? So that was going to be done in the next few hours. So we went on, because we finished our work, so we went on, went home, and a few hours later at home, I got a call from the registrar saying, MRI was done. It didn't show what I suspected as. There was no evidence of PRES or cerebrovenous thrombosis, but actually the MRI, okay, because there were other sequences, also showed changes, surprisingly showed changes of ischemic changes. And the blood vessels showed narrowing with bleeding, suggestive of vasculitis. Now, actually, I didn't suspect CNS vasculitis, lupus-related CNS vasculitis in my differential diagnosis. But luckily, I got away with it by pure luck because the MRI had sequences that helped that. But here again, it shows you how my cursory examination at the beginning, when I said probably migraine, let's start treatment and let her go up to the ward for observation. Okay, turned out to be something much more sinister. And luckily, we got away with it because we decided at the end to apply a systematic formula rather than rely on gut feeling and things like, patient looks well, doesn't look toxic, and things that we often use very loosely without really understanding what the real implications are. So let's think about all the ways that I went wrong in this. So framing biases, I've already mentioned to you, right? Depending on how the information is given to you, you can come to different conclusions. So you have to be aware of that. Anchoring bias is basically relying on information that comes to you at the beginning. The patient has migraine. It's somebody else who's already diagnosed migraine. She has migraine. So straight away, it's migraine, without thinking about, so premature closure of the diagnosis. First impressions, that's it. And then confirmation bias is an extension of that. Once you've made your first impression, you're only going to get information that is going to support that. You're not going to look for information that's going to go against it. So that's confirmation bias. So I was guilty of all these three biases. Other errors in this case, okay, there's this common fallacy among all of us that neuroimaging, CT scan, MRI, all these things will cure or rather conquer all headaches, purely all-encompassing diagnostic tools. But we know that meningitis, CT scan and MRI can be normal. Temporal arthritis, life-threatening and limb-threatening and eye vision-threatening condition, right? But the MRI will be normal, correct? Similarly, subarachnoid hemorrhage, especially if it comes a bit late, the CT scan can be normal, and the only test that can prove the final diagnosis would be spinal tap for xanthochromia. Okay, so remember, by doing some form of imaging doesn't mean you have covered all the bases. You have to decide what is the pre-test probability of the condition that you're thinking about, and what test that pre-test probability predicates. Okay, then the fallacy of therapeutic trial. Now, we would never give painkillers for an acute abdomen, and just because the pain got better, sorry, an undiagnosed abdomen, just because the pain get better, we say, oh, this is not acute abdomen. We won't say that, right? So likewise, we should never dismiss a headache just because it gets better. Okay, you are allowed to use, of course, you must give patients the painkillers, right? But the response to the painkillers is not a diagnostic tool. Okay. But on the other hand, after you've made a diagnosis of migraine, status migrainosis, of course, your duty as a physician, our duty as a physician is to alleviate the suffering by treating the patient properly. But don't use a therapeutic trial, okay, as a diagnostic tool. And finally, use a systematic, especially when it's a complex disorder like complex as I've illustrated, although common, still can be complex. Most clinical problems can be complex and require a systematic algorithmic approach rather than gut feeling, oh, I think this is this, I think it's that. No, you should use a systematic approach, okay? So that the next patient is this patient that I've heard in, and I will explain how I heard of this patient and how subsequently somebody else came and got the diagnosis correct, maybe when we have time during the question and answer session. So I'll go on to summarize by going through the key headache metacognition points that I've covered. Firstly, the 3-question approach helps you look at all the data in total rather than act on one piece of information. For example, headache with vomiting may be okay in a patient with pre-existent migraine, but it can mean raised intracranial pressure in another context. So always look at the pieces of information in the context of the 3 questions. Okay, the patient's comorbidities and the patient profile changes how you collect the other information, and I've illustrated it with that example that I gave you. Now, after formulating a list of possible secondary causes, decide what is the pre-test probability of each one of them, and then decide whether you need a very sensitive test or a simple, non-sensitive, non-specific test, depending on how suspicious you are of that particular condition. Okay, and remember, neuroimaging does not conquer all headaches. And then we already alluded to the fallacy of treatment in undiagnosed headaches. And then this, we didn't really mention it in the first case, but it will come clear in the second case. Don't factor psychosomatic factors in the diagnostic stage. Psychosomatic factors should only come in after you have diagnosed a particular condition that's often associated with psychosomatization. Okay, because when you ask somebody who's whether they are stressed, everybody will be stressed. A patient with meningitis is stressed because he cannot get to work the next day. His colleagues are all going to complain that he's on medical leave and things like that. So of course he's going to be stressed. Just because he's stressed doesn't mean his meningitis is not meningitis, is psychosomatic headache, right? So we will illustrate that with a second case. And then finally, this is not really covered in our cases today, but I always feel that we should avoid, in the emergency setting, we should avoid opioids for chronic headache patients, chronic pain patients, because otherwise we will end up where the Americans have ended up with an opioid crisis. Okay, with that, this is a summary slide, and there will be, I've made this into a handout for you to refer to. when you see patients next time. Okay. With that, hope to see you on the actual session where we can address some of your questions and talk about the second case. Thank you.